Good morning. My name is Hyun from the Catholic University of Korea. Thank you for inviting me. The presentation I'd like to share today discusses cases of generalized patchy hypomelanosis of childhood. Hypopigmentation is a frequently encountered problem in children. According to the extent of the lesion, differential diagnosis includes a variety of disorders. However, sometimes hypopigmented lesions can be difficult to distinguish with naked eyes under the room light. Ultraviolet photograph has improved the image quality so we can assess the border, shape, and extent of the lesions more accurately. It allows us to recognize the differences between diseases, and recently we have identified some cases that showed different features from any of previously known hypopigmentation disorders. Here are the cases where diagnosis cannot be made. Please try to make your diagnosis in mind as we go over each slide. First case was a 7-year-old boy who presented with hypopigmented patches without any scale or preceding erythema on his shoulders and trunk for 1 year. He didn't have history of atopic dermatitis. At closer view, the lesions were characterized by well-demarcated irregular borders, and diffuse patches were coalescing into larger patches. Another 7-year-old boy with similar lesion, he didn't have any preceding inflammatory lesions or atopic dermatitis. The lesions showed rapid improvement after 3 months of excimer laser treatment. Again, you can identify well-demarcated patches in geographic pattern, symmetrically distributed. Third case, a 4-year-old girl who developed hypopigmented patches on her shoulders, back, and lumbosacral lesion without any preceding dermatitis. It has been progressing for 10 months. After 3 months of excimer laser treatment, the lesions were cleared. Moving on, 5-year-old girl with no history of atopic dermatitis developed diffuse, non-scaly, symmetric hypopigmented patches on the trunk and proximal limbs for 6 months. Another 7-year-old boy who developed similar lesions 1 year ago. Geographic patches were symmetrically distributed over the trunk and shoulders. In all cases, fungal smear was negative and skin biopsy revealed normal melanocytes and slightly decreased melanin pigment in the basal layer. That brings us to differential diagnosis. Petrosis alba, hereafter called PA, is ill-defined scaly patches on the face resulting from post-inflammatory changes or ultraviolet exposure. Extensive Petrosis alba is an atypical variant of PA, which involves trunk and extremities. Case series have been reported in literature, but a clear definition for extensive PA has not yet been established. Petrosis versicolor presents as well-defined circular scaly macules over the sebaceous areas. Hypopigmented mycosis fungoides presents with fine scales and is usually confirmed through pathologic finding. Progressive macular hypomelanosis is nummular confluent and usually affects young adults. Regarding the onset age, fungal smear, and pathologic results, Petrosis versicolor, mycosis fungoides, and PMH were ruled out. Our cases might look similar to PA or extensive PA with the naked eyes, but with an ultraviolet image, several distinct features became noticeable. Compared with PA, our cases were characterized by relatively distinct and irregular margin, with large coalescing patches in geographic pattern. Our cases were absent of scales. The age of presentation ranged from 4 to 7 years old, and typical distribution was over the trunk, shoulders, and proximal limbs, which reflects there's no association with sun exposure. Associated atopic dermatitis was not relevant in our cases. Taken together, our case was considered to belong to a distinct classification. In conclusion, we propose a novel disease entity called Generalized Patchy Hypomelanosis of Childhood. To summarize, this disorder is characterized by relatively well-defined and coalescing hypopigmented patches distributed symmetrically over the trunk and proximal limbs in children. It may last for several months to years and seems to resolve spontaneously because it's not observed in adults. Further studies about pathogenesis and long-term follow-up with larger sample size will be necessary. Thank you for listening.
Thank you very much. Thank you very much for this very nice talk. We can see if there is any question, because any speaker can have some minutes to provide answer live, or otherwise you can answer later to the question that you can find on Q&A.
Can I have a small question?
Sure.
Yes, sure.
Yes. Did you follow up the patients after you did the excimer?
After excimer laser treatment?
Yes, after repigmentation happened, did you follow them up to see did the depigmentation return back or the hyperpigmentation return back or not?
Well, you mean after stopping excimer laser treatment?
Yes.
The lesions recur after when we stopped.
It recurred back.
Yes.
So it's acting a little bit like the depigmented nevus. Depigmented neva, usually they repigment and then it disappears again.
Yeah. Yes, but the clinical manifestation was totally different from nevus depigmentation.
Yes, it's very interesting. Thank you.
Yeah.
And one more thing to add, I think it's a long way to determine the disease name or terminology, but I hope today's presentation brings us opportunity to collaborate and collect similar cases and further classify in the near future. So anyone who's interested or experienced similar cases, please share freely with me or Dr. Jeong Bae. Thank you.
Maybe I would like to ask a question. Just thank you. The presentation was really excellent presentation, and very interesting cases. I'm just wondering, because the kids are very small, is there, I don't know if I have seen a patient like this, and I will share with you my case without any problem. I can give it to you, but my question is it mosaicism that exists since the beginning, and you just see it once the patient goes for the first time to sun, and maybe in the beginning the lesions are present at birth, but you can see them and they reveal later?
Sorry, you mean it's related to mosaicism?
If it is related to mosaicism, and if the lesions are already present at birth.
Since birth.
Yeah, since birth. And then they just revealed with time, but they are here when the children at the birth, and it's just that you can see them because the melanocyte differentiation become clearer when the children grow up.
But like it presented from like 4 years to 7 years old, and most of the parents said it presented about 1 year ago. And as we followed up, the lesions keep spreading. So there could be another factor causing the melanocyte dysfunction in melanin pigmentation production or transfer, or maybe it could be a genetic inborn factor, of course, but I think further studies will be needed.
I think we should also consider it might be an early form of vitiligo that will proceed later on, which when depigmentation is not complete, we only have hypopigmentation. But I don't know, maybe the pathology did not show any inflammatory changes.
Mm-hmm.
Did it?
No.
Thank you.
Okay, thank you.
Thank you.
Thank you.